Positioning for spinal surgery. My name is Thomas Buell. I'm a resident at the University of Virginia. Positioning on the operating table is one of the most critical first steps in performing any spine surgery procedure. Ideal positioning facilitates access and ease of exposure, while simultaneously minimizing risks of bleeding, likelihood of damage to vital structures, and other morbidity. Over the years, there have been several advancements, including improvements in operating tables, frames, and other devices, aimed to make surgery more safe and efficient. We'll review some of these major advancements and discuss common equipment currently available, with special consideration and focus on strategies to reduce risk of complications. When patients are prone, there can be increased intra-abdominal pressure from extrinsic factors. Subsequent elevations in central venous pressure may preferentially divert returning blood into the normally low pressure valveless thin-walled vertebral veins via Batson's plexus. The result is vertebral venous engorgement with potentially increased surgical blood loss. Therefore, keeping the prone patient's abdomen free of restriction was a guiding principle for many positioning techniques, tables, and frames. This includes positions previously described for lumbar decompression or discectomy, including Ecker's kneeling position, Tarlov's knee-chest position, and Wayne's tuck position. These surgeons recognized the relationship between restrictions on the prone patient's abdomen and prevention of surgical ooze for blood loss reduction. Another potential benefit with these positions was reduced lumbar lordosis, achieved through hip flexion, could potentially widen interlaminar spaces to improve disc access with less bony removal. Several frames for lumbar decompression or discectomy were designed based on these principles. In contrast, positioning for lumbar instrumentation or arthrodesis must balance goals of reducing abdominal compression while preserving lordosis. With Harrington rod instrumentation increasingly utilized in the 1960s, Relton and Hall designed the first frame to adequately support these scoliosis operations without allowing external pressure on the anterior abdominal wall. The Relton-Hall frame consisted of 4 well-padded vertical supports arranged in 2 V-shaped pairs to support the upper thoracic cage and iliac crests. Use of the frame was associated with less blood loss during Harrington rod scoliosis operations. The Jackson modular table is the most common spine-specific positioning system used today, especially for instrumentation cases. The table's carbon fiber open frame design allows unobstructed radiolucency and supports C-arm or advanced navigation imaging integration. The Jackson table can be fitted with a spinal top for prone cases or a padded radiolucent imaging top for operations that require supine or lateral positioning. Next, a Wilson frame can be fitted to the Jackson table for further manipulation of thoracolumbar sagittal contour. The Wilson frame can also be used with a standard operating table, which is a common positioning setup useful for lumbar decompression or discectomy. Please refer to the chapter and accompanying videos which cover the Jackson table, its rotational capabilities for unstable spine trauma or circumferential surgery, the Wilson frame, and its available hand-lever crank system for adjusting thoracolumbar sagittal contour. Here are some common examples of setups for prone positioning. Prone Superman positioning is demonstrated in this patient undergoing posterior thoracolumbar instrumentation on a Jackson table. The patient's head is supported by a foam protective helmet to avoid direct ocular pressure. Approximately 10 degrees of reverse Trendelenburg positioning is recommended. Note the upper extremity placement on a padded arm boards and the shoulders abducted and elbows each flexed less than 90 degrees. Next, prone position with arms tucks is demonstrated. We tuck the arms for spinal pathology cranial to approximately T6. Supine patient positioning is often used for anterior cervical and anterior lumbar approaches, with the prototypical operations being an ACDF and anterior lumbar interbody fusion. In this patient positioned for an ACDF, we use a weighted chin strap to increase cervical extension and keep the mandible out of the surgical field. Avoid excessive traction when applying shoulder tape. Keep the patient's forearms in neutral position and ensure the elbows are well padded. Further details of supine positioning can be found in the chapter and accompanying videos. Here we demonstrate positioning for lateral interbody fusion. Like the prone Superman position, patients placed in lateral decubitus position may have significantly higher incidence of position-related upper extremity nerve injury, which can be detected by neuromonitoring. Note the upper extremity padding and how we have kept the arms approximately parallel to the floor, avoiding excessive elbow or wrist flexion or extension. Also, we place pillows between the lower extremities to avoid pressure ulcers. A final safety check should be performed to ensure appropriate patient positioning with well-padded pressure points. Avoid direct contact of the patient's skin with equipment to minimize risks of soft tissue breakdown or pressure injuries. For prone positioning, we re-emphasize the importance of having the breasts, abdomen, and genitalia hang free from compression. Some sporadically reported complications of inadequate positioning include shoulder dislocation, lower extremity compartment syndrome with myoglobinuria or acute renal failure after prolonged knee, chest, or tuck positioning, and ischemic medullary syndromes from improper head rotation and likely diminished vertebral arterial flow. Next, we describe two important position-related complications: perioperative peripheral nerve injury and vision loss. Ulnar neuropathy is the most common upper extremity perioperative peripheral nerve injury after spine surgery. This complication occurs more commonly in men and frequently has delayed onset, with symptoms manifesting within a week of surgery. When positioning, be wary of progressive shoulder abduction, elbow flexion, forearm pronation, and wrist dorsiflexion, which can stretch the ulnar nerve, decrease the cubital tunnel's cross-sectional area, and increase ulnar nerve pressure. Brachial plexopathy is the second most common upper extremity perioperative peripheral nerve injury associated with spine surgery, and it usually involves upper nerve root injury from excessive downward traction on the shoulder, arm mispositioning, or prolonged neck extension. Median and radial nerve neuropathies are less common. Lower extremity perioperative peripheral nerve injury may involve the common peroneal nerve, which is susceptible to injury at its superficial location near the fibular head. It can also involve the lateral femoral cutaneous nerve causing meralgia paresthetica, which usually has a benign course. Multimodal assessment of somatosensory evoked potentials and motor evoked potentials is primarily used to monitor spinal cord integrity during surgery. However, intraoperative neuromonitoring may also prevent the occurrence of perioperative peripheral nerve injuries related to positioning. Amplitude and latency changes in signals can indicate impending nerve injury. These signals can guide modification of patient positioning and restore baseline signaling. Postoperative vision loss is a rare but potentially devastating complication after spine surgery. When it occurs, it is frequently bilateral. The visual deficit is often irreversible and with complete blindness. Currently, there are no effective treatments. Therefore, focus should be directed towards prevention, identifying potential risk factors for modification, and implementing safe positioning techniques. Direct pressure on the eye from improper patient positioning may increase risk of postoperative vision loss. Therefore, vigilance regarding safe eye protection is important. Techniques to reduce intraocular pressure should be performed when positioning patients. This includes utilizing reverse Trendelenburg positioning, maintaining the neck in neutral position to reduce risk of jugular vein or carotid artery compromise, and use of cranial fixation with a Mayfield clamp to avoid external ocular compression. In conclusion, in this chapter we review important principles of positioning patients for spine surgery, with special consideration and focus on potential strategies to reduce risk of complications. Prone positioning for spine surgery is common, and it is important not to forget the associated distinct physiological changes, especially cardiopulmonary, that can occur when prone. Prolonged prone positioning in high-risk patients carries elevated risks of complications ranging from mild soft tissue sores and self-limiting meralgia paresthetica to more severe vision loss, including complete blindness and permanent peripheral nerve injuries. Therefore, meticulous attention is required for optimal and safe patient positioning, and operative team members should communicate and work together to monitor impending position-related complications that can be avoided if corrective and prompt action is taken.